We're going to talk about laser trabeculoplasty. And just a disclaimer, and I'll have this in most of my surgical talks, you really can't learn to be a surgeon by watching a videotape, just like you can't learn to swim by watching a videotape. What I'd like to do is just give you the science behind trabeculoplasty, why we do it, and a little bit about how it's done. But please learn to do it from a mentor. I'm going to talk about two, argon laser trabeculoplasty and selective laser trabeculoplasty. Those are the two that are most commonly done presently. Selective laser trabeculoplasty quite a bit more now than argon laser trabeculoplasty. There are others. Trabeculoplasty can be done with the diode laser, or more recently a micropulse diode laser. But there's not a lot in literature on this last variation. So trabeculoplasty dates back to 1979 and is a way of treating the trabecular meshwork with laser energy to increase trabecular outflow, conventional outflow. Therefore, really not that helpful if you have somebody with normal tension glaucoma and the target is 9 or 10 millimeters of mercury, because it will, relying on trabecular outflow, will be limited by episcleral venous pressure. The exact mechanism by which trabeculoplasty causes pressure to go down is really not known. When ALT first came out, it was proposed that there was shrinking and opening up in the intervening spaces between the laser spots. It's now felt that the laser stimulation releases chemical mediators that modify the trabecular meshwork, and there's an increase in monocytes and macrophages. We tend to do this for people with open-angle glaucomas of a variety of types. Primary open-angle glaucoma, it's particularly effective in angles that are pigmented, like exfoliation syndrome and pigmentary glaucoma. In the U.S., it's typically used after medical therapy, but it can also be used primarily or early in the treatment algorithm for somebody who has trouble with adherence, just really can't get drops in. It's less likely to work in people who are aphakic, have angle recession, inflammatory glaucomas, congenital or developmental glaucomas, or juvenile glaucoma. It doesn't mean that it will never work in those situations, but it's less likely to work. And really contraindicated in people with angle closure. Obviously, you need to have a view of the angle to do trabeculoplasty. So neovascular glaucoma, the ISIS syndromes, and other angle closure glaucomas. And as I said before, glaucomas in which the pre-procedure pressure is near episcleral venous pressure. So it works better on eyes that have a somewhat higher intraocular pressure than eyes that have low pressure. It's about as effective as adding another drop. We usually pre-treat with an alpha-adrenergic agonist like aproclonidine or brimonidine, but brimonidine is a lot more available these days. The argon laser trabeculoplasty is either green or blue-green, delivered through a lens, a Goldmann style contact lens. The rich lens has a magnifying buttons on it, and that can also be used for trabeculoplasty. There are lots of lenses that can be used, but they're all variations on the Goldmann style lens. It's a small spot size, 50 microns, short duration, 0.1 second, and the power is titrated between 200 and 1200 milliwatts. One can either treat 180 or 360 degrees with anywhere from 40 to 100 spots. One aims at the junction of the pigmented and non-pigmented trabecular meshwork, so you need to be good at gonioscopy. This picture was the last picture of the angle that Lee Allen ever drew, and he drew it specifically for me to show trabeculoplasty. And our goal is to get blanching or a small bubble formation. We don't want an explosion just a small reaction. SLT is newer. It's a Q-switch frequency doubled neodymium YAG laser. Again, this is delivered through a Goldmann style lens. There is a Latina lens that is specifically designed for SLT. It has a fixed spot size that's much, much larger. So instead of 50 microns, it's 400 microns, and it really covers the whole trabecular meshwork. The duration is also fixed at 3 nanoseconds, and then the power is adjusted until one sees champagne bubbles, these fine bubbles that come off the trabecular meshwork. Some people will continue to treat at that energy level. Others will get to the champagne bubbles and then back off until no bubbles are seen. And one can treat over 180 degrees or 360 degrees. These spots are confluent right next to each other. They're very large spots. It's very hard to see them in crisp focus because it's a very large defocused spot. Somewhat easier to do than argon laser trabeculoplasty because it doesn't require quite such precise aiming. One of the few post-op complications with trabeculoplasty is an elevated intraocular pressure, so we usually check their pressure an hour or two after the procedure. One can either treat with prednisolone or not. I always treat after argon laser trabeculoplasty, but not for selective. And follow them in 6 or 8 weeks to make sure that the procedure has been effective. Complications are uncommon, generally mild. As I mentioned, there can be a transient elevation in intraocular pressure. The alpha-adrenergic agonists like brimonidine have really decreased this problem. One can see mild inflammation. Peripheral anterior synechia can develop, particularly in eyes that have narrow angles or where the aim is much too posterior. So this is a patient who had laser trabeculoplasty performed in an angle that's really too narrow for trabeculoplasty. And you'll see that there are intermittent spots where it looks like the iris has been welded to the meshwork and to the cornea. So I would not do this procedure in somebody who has very narrow iridocorneal angles. It's a good way to weld them closed. There is a randomized clinical trial, the Glaucoma laser trial, or GLT, which took place in the 80s. And the idea of this study was to look at argon laser trabeculoplasty versus medical management. And medical management at that time was 0.5% timolol twice a day. In the first 2 years of the study, the laser-treated eyes had lower intraocular pressures and fewer added medication. But over time, the laser-treated eyes gradually required the addition of medication. It supported the use of early trabeculoplasty in that era. Obviously, today our medical options are different. Back then, the prostaglandin analogs were not available. So the glaucoma laser trial has a little bit less applicability to us today, both because we have different medicines and because the laser is different. So the key points with trabeculoplasty: it stimulates aqueous outflow through the trabecular meshwork. It has a similar effect as adding another drop. It's used in open-angle forms of glaucoma. The risks are small, mostly transient rise in intraocular pressure. So trabeculoplasty is something that's in everyone's armamentarium pretty much, who takes care of patients with glaucoma. It's not technically challenging to perform, and it's an important adjunct to medicines and generally before surgical intervention.